What's up?
I am doing it. Yeah.
Yeah. Dr. Hemant, I just told it to Arul sir in the morning that all of a sudden, from Bangalore, also from Op Society, they said that our team of doctors also would attend. So me and Rajesh sir, we were just fixed, we had kept it for 1,000. Then I said, okay, let's have it a little more. So that's how the change in the link, and then we thought it will be better way
Can we
of
go live
approaching
on audience
that.
link?
Yeah. So what's up?
Can we go live on audience link?
I think we have another 1 or 2 minutes. This video is seen, na?
No, so
Chetan?
this video as of now not yet. Once we have to go live, then they will able to see the
Okay,
video.
just the video, not our chat, right?
Yeah.
Okay, yeah, you can go live then.
So we are live on audience link. It is completely visible.
Okay. Shweta, you can just give us a prompt or once we need to start. Ananta?
Yes, ma'am.
Ananta, please
Ananta,
allow
how
everybody
many
to on.
as of now?
Sorry?
Or people are just joining?
Yeah, there are many people joining. Please allow
Okay.
them to on their cameras, video cameras, and
Yeah, we are already doing it. Everyone have a right, whoever is joining from this link.
Oh, presenter. They can. Hello, Ananta.
Yes, ma'am.
Ananta, there are other doctors also who are going to talk about the book. Can you just allow them?
Yeah, we have already allowed them. You can see in the list there are 13 people has already
13
joined.
participants. Okay.
Yeah. So
we cannot see them. That's why.
Yeah, they have to turn on the camera. Okay.
May we request doctors to please turn on their cameras?
Right now the share screen is going on, so that's why you can able to see the limited videos. The moment screen sharing will start, you will able to see the more videos.
Okay. We have Dr. Tripura Sundari from Hyderabad, Sujanya Josh from Bellary, Fagun Shah from Ahmedabad. Yeah, all of you please turn on your cameras.
Maja from Warangal. Yeah. Okay.
Ananta, just see, I am surprised how come we are not able to see any other participants here. Yes. At least Dr. Prasad we have been able to see. Hello, namaste, madam.
She's on mute.
Uh-huh.
So madam has come.
Yeah. All the doctors on presenter link, I would request you to please open your cameras. I think it's
Dr. Padmini, good afternoon. We want you to open your video.
मैं वीडियो
Madam,
स्टार्ट
video.
कर रही हूँ तो मेरा होस्ट मेरे को ये कर रहा है, डिसेबल कर रहा है.
To some other link.
वीडियो स्टार्ट नहीं हो रहा मेरा.
श्वेता बोलो जरा.
नहीं. ओके.
Sorry, ma'am.
In 2 minutes, I guess we have to start.
Yeah. Need to give
Yeah,
some-
Dr. Padmini Prasad, namaste. We can see you live. Glad to have you here, ma'am.
Namaste, madam.
Namaste.
Welcome.
Good afternoon.
Oh, good
Good
afternoon.
afternoon to you all. I was
Yeah.
in the OT, so I was
Can we
just
start?
in the OT, so I had to just change
Yeah,
it.
yeah,
and
great, great.
come. Okay.
Yes, yes, sir, it is moving.
Reshmi, isn't it time to start, Reshmi?
Okay.
Shweta, just take a call. How many? If 100 doctors are there, maybe 5-10 minutes, everybody would join. We can start the session.
Yes, yes, ma'am.
Conscious call.
Yes.
Malini Appan sir, what do you suggest?
We should start. Sir,
88,
Just check the number, Shweta.
Yes, yes, sir. Yes, ma'am.
90.
90. Okay.
Yeah.
Let's wait for 2-3 minutes.
Yeah, yeah.
I think 100 is a good number, right?
Yeah,
101 maybe, an auspicious number. Ananta, you can tell the moment it is 100 plus. We will start.
Sure, ma'am.
Ma'am, it's 100 plus, 125 plus.
Oh, wow.
Oh, good.
Yes. Yes.
So, with your permission.
May I request now Rajesh sir to please start? Yeah. Over to our Vice President, Rajesh sir. Yes.
Hello, good evening. Sir,
Hello.
good evening. Good evening, sir. Dr. Hemant Deshpande, can you hear me?
Good evening, ma'am. Good evening. I can
Rikumaran, sir, good evening.
आज वीडियो कर रही हूँ.
Hello,
ठीक है.
Rashmi.
ओके, 1 मिनट. हाँ हाँ, ठीक है, अभी आ गया. हाँ, ओके, ठीक.
Rashmi, can you hear me?
Yes,
Yes,
yes, I
yes,
can
ma'am,
hear you
yes.
very well.
Yes, ma'am.
Hello.
Today, too many seminars, same time, 4 to 6.
Yeah.
Shweta, you can stop sharing the screen. We will be starting the session. Shweta?
Hemant, sir, you are telling in detail about the pathophysiology, right, sir?
Pardon, ma'am?
You are telling in detail about the physiology of sildenafil, no, sir?
Yes, ma'am. Yes. Trying to cover as much as possible, which I can.
No. I guess just, I won't repeat anything.
Tripura, madam, your video is off.
Yeah.
No.
I can't see.
Madam, మీ video off ఉంది.
Video off, Tripura,
Video
madam.
on చేయాలి, ma'am. Video on
You see
చేయాలి.
now?
కాదు ఇంకా రాలేదు. Tripura madam, namaste.
Namaste,
Video on
sir.
చేయాలి, ma'am. Yeah.
I can't see Dr. Tripura, madam.
Yes,
No,
sir.
I also can't see.
Yeah, Tripuram, please on your video webcam.
I have switched it on, but somehow it's not coming. I'll see.
Many of your students would want to see you, madam. Yeah. So namaste to all of you. May I now request our Vice President Rajesh Gurani, sir, to please start the session. Over to you, sir.
Sir, so very good evening to all the doctors. First of all, greetings from Acumentis Healthcare Limited, the India's fastest growing company. Acumentis is an Acums group company, and Acums being the largest manufacturing company of India. We are the second largest in Asia. I take this opportunity to welcome all the respected speakers and the audience doctors. As the physical meetings are not possible during the lockdown, we are happy that we are able to be connected with the doctors virtually, which otherwise is generally not possible. Today, I feel honored in welcoming our speakers from London, Dr. Sabratnam Arul Kumaram. He needs no introduction. Sir is a global authority. I was just talking to him, listening to his views. It was a delight. Welcome, sir. And our second speaker today is Professor Hemant Deshpande. Dr. Hemant Deshpande is renowned doctor from D.Y. Patil. And we hope that he occupies a bigger position and responsibilities in future to contribute to the medical fraternity. Welcome, sir. And we have our moderator, Dr. N. Palaniappam. Welcome, sir. Sir is a very known, well-known figure from SRMC Chennai. Welcome, sir. You are all experts and super experts in your field. And sir, the CVs will be flashed in a while. Many of you are, so celebrated. It is almost like, reading a 1,000-page book. While I am seeing your CVs, it is so celebrated CVs. Thank you so much for being with us. And I request Rashmi to please take this session forward.
Okay. Thank you, Rajesh, sir. First of all, namaste to all of you, all the doctors, and a very warm welcome to deans and dignitaries, madams and sirs, professors and students, our CEO, Padam Patni, sir, and Executive Director, Kanish Jain, sir, and my dear colleagues. I believe that today is really a very, very auspicious day where all the gurus have actually gathered. So with that view, I believe that I must chant a Sanskrit shloka. Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Param Brahma, Tasmai Sri Gurudev Namaha. So we really feel super blessed to have you all amongst us. And our moderator today is Dr. Palaniappan sir. So may I request Shweta to please share Palaniappan sir's CV? Kindly flash it. We all know Dr. Palaniappan sir very well. Just to brief you, he is professor and unit HOD of Ops. Yeah, she's sharing.
It is shared. It is shared.
We can't see that, Shweta.
It is so.
Yeah, just share it.
Yeah.
Not yet.
Yeah, we can see the screen.
You can see the screen now?
We can see that you're
Definitely it is
sharing.
not coming.
However, we cannot see the content.
Just a second. I'll share it again.
Yes. Yes, we can see it. Thank you, Shweta. So Dr. Palaniappan is professor and unit HOD of Ops, Sri Ramachandra Medical College, Chennai. And he has won Indumati Javeri Award in 1994 and a Young Scientist Award in 1996. Dr. is Senior Overseas Fellow, Liverpool Hospital, Sydney, and he has been an orator in Dr. Kamini Rao Yuva Foxy. Doctor is young, has received Young Gynecologist Award of Asia Oceania Federation of Obstetric and Gynecology 2007, and he's a speaker at various national and international conferences. Dr. Palaniappan has authored many chapters in various textbooks, and he has major interest in high-risk obstetrics. Doctor was Joint Secretary of All India Congress of Obstetrics 2015 Chennai, and he is President of OXY 2020. Dr. Palaniappan was Chairperson of Safe Motherhood Committee FOXY for year 2017 and 2019. And currently he is a governing counseling member of ICOG 21 and 23. So may I now request Dr. Palaniappan sir for the scientific proceedings with the intro of Sirs of Many Sir, that is Sir Sabaratnam Arul Kumaran, and with the floral bouquet to Dr. Palaniappan. Virtual stage is all yours, sir. Over to you, Palaniappan sir. Shweta, kindly flash CV. Over to you,
Thank you.
Palaniappan sir.
Thank you, Reshmi, for this wonderful opportunity. It's indeed my pleasure to introduce Dr. Sabaratnam Arulkumaran over to this audience. And it is always a pleasure and it is a pride to introduce Dr. Arulkumaran. He's not a newcomer to India, and any podium where Professor is there, and we deem it an absolute honor. And Dr. Arulkumaran is the Professor Emeritus of OBG at the St. George's University of London, Professor of OBG from 2001 to 13 at the St. George's University of London, and Foundation Professor of ONG St. George's Medical School University of Nicosia from 2014. And he as a visiting professor in Institute of Global Health Policy Innovation, Imperial College London from 2012. And to state so, more importantly, he was the past president of FIGO, the British Medical Association, and the RCOG of London. He was appointed Knight Bachelor by Her Majesty the Queen of the UK in her birthday honors list in 2009 June in recognition of his services to medicine and healthcare. And he has written 38 books, 315 publications, reference journals are to his credit. And none of the textbooks would be without Dr. Arulkumaran's reference, and we would quote him as Bhagavad Gita, Bible, or whatever you want to call it as. And his books on the Elsevier content, which goes on as a Brown journal, is probably the one which we would refer to for any recent advances. And we have a very odd topic. Where do we go and look into? We'll say go and look into Professor Sabaratnam Arulkumaran's topics. And so that is what is the beautiful academic achievement which he's had over so many years. And I deem it a pleasure to introduce Dr. Arulkumaran, and he's going to speak to us on a topic which is dear and near to him and to all of us: recent advances in postpartum hemorrhage. Over to you, sir, for the lecture. We are on.
Thank you. Thank you very much, Professor Palaniappan, for the very kind introduction. It's fantastic to be with you. And I hope I can meet the aspirations of what you mentioned. So I'll try my best. But first, I would like to thank Rajesh Guhani and Rashmi Tiwari for inviting me to the podium. And also, it's a pleasure to talk at the same podium like Hemant Deshpande, with whom I have lectured when he was chair of the CPD committee of the FOXY. And I'm sure he's aspiring to do other things for FOXY, and I wish him all the best. And I'm sure he will do it to his full satisfaction. And there are many I can see who I know, so I won't mention all the names because it'll take time off my lecture. So with your kind permission, I will share my talk. So as we know, postpartum hemorrhage is actually causes 30% of maternal deaths in the global scene, at least 25%, although it is much less in the high-income countries. No conflict of interest related to the lecture. And for this lecture, I've taken 3 learning objectives. One is actually, it's most important to look at confidential inquiries and to look at what are the best methods of monitoring blood loss. Is it just estimation? Can we rely on the pulse, blood pressure, shock index, and use a modified early warning obstetric chart? The second objective is, should we seek for better drugs for prevention and early treatment? There are a number of drugs available: oxytocin, ergometrine, sitametrine, heat-stable carbetocin, and tranexamic acid for early treatment. So I'm going to really look at the Cochrane database and the analysis, network meta-analysis, to see what we should do. And finally, some early surgical treatment in terms of suction tamponade and other methods. And also with placenta accreta, can we modify our technique to avoid maternal deaths? So we come to the first objective. Monitoring is quite important because we can reduce the total amount of blood loss by having early intervention. I'll talk a little bit about shock index in terms of monitoring. In terms of prevention, I will talk about heat-stable carbetocin, early treatment, tamponade devices, and tranexamic acid. And finally, one slide each on transport, transfusion protocols, and triple P procedure. Now, in a place where there is no charts available, I would really advocate rule of 30. That is, if there is a 30% blood loss, more then the woman goes into moderate shock. She causes vasoconstriction of the skin, muscles, the viscera, and so on, because of 30% blood loss. And at that time, there should be an increase of pulse rate by 30. Respiratory rate might go close to 30, might be 25. Systolic blood pressure might drop by 30, urinary output by 30 per hour, and there's a hematocrit drop. And if you want to combine the systolic blood pressure with the pulse, then we call it the shock index. So if my systolic blood pressure is 120 and the pulse is 60 over 120, shock index is 0.5. And this can change by 30%. That means she has lost moderate amount of blood. So we will look into these indices when we look at the early warning score chart, why we say the rule of 30 is quite a useful index if we don't have a chart to monitor. Now, this is on one side is the early warning obstetric score chart. I will show a blown up picture. And the second picture is about the pictorial guide of blood loss. Now, the problem with the pictorial guide is it's good to have estimate. You can weigh the pads before you deliver and after it is soaked. That is one way of weighing measurement. Second is you can use a drape, but those are all complicated. So you can have a guesstimate. If it is flowing down from the bed, then it's probably more than 2 liters. If it is soaked in the bed, 1 liter. But this quantity doesn't really tell us what is going to happen with a woman, because the woman will respond according to the body weight, because every kilogram, she has 100 ml of blood. So if she is 40 kilogram woman, she has 4 liters. She's 70 kilograms, she is 7 liters. So 70 kilogram woman, she might lose 1.5 liters, but she won't have much of a change because it is less than 30%. But if she is 40 kilograms, she will show a change. And the second, if she is anemic, she will show a rapid change because pathologically she can't tolerate it. So anemia and body weight can influence whatever you measure is not going to influence your thinking. That's why it's important to have the pulse, blood pressure, temperature, everything. So this is the early warning obstetric score chart. It is exactly a pulse, blood pressure, temperature chart which you use, but it is color coded. So as you can see, the respiration goes beyond 21, it goes into amber, over 25, it goes into red. Similarly, the temperature and the heart rate, if you see 90 to 110 is amber, and over 110 goes into red. That's why I mentioned about shock index or looking at the rule of 30. So if it goes from 90 to 110, 120, that means over 30. And similarly, the systolic blood pressure is plotted differently from the diastolic blood pressure because you can use the same chart for preeclampsia as well as for PPH. So if the woman has 120 and drops to 90, she goes into amber. Until she is 110, it goes into 80 systolic. That's 30 millimeter difference. She goes into red. So that's why the rule of 30 is quite a useful index for you to follow. And same, you can mention about the PV blood loss, but you have to combine both parameters. Now, it is also important to have a communication tool. So we use ISPA, identify, explain the situation. There's a woman like this who has lost so much of blood. This is a pulse, blood pressure. This is the background. She had multiple pregnancy or fibroids or whatever it is. And this is your assessment and what should be the recommendation. So this is a communication tool between the staff on the labor ward floor and the consultant. Now, this is the first paper we published on the shock index of the pulse divided by the systolic blood pressure. And we showed that in pregnancy, the shock index is 0.7 to 0.9. And there have been recent studies in 2018 saying if it increases by 30%, it identifies significant PPH. And if it further increases by 30%, that means they need some intervention surgically and medically. And therefore, it is quite a good index to think about. And it's not difficult because when you plot the pulse going up and the blood pressure coming down, when it cuts each other, the shock index is 1. Now, the second area I mentioned was about the use of oxytocin. This was a landmark paper from the WHO in Lancet 2013. Now, if you look at the horizontal bar, you can say the patients are divided according to low maternal mortality, moderate, high, and very high maternal mortality rate countries. If you look at the coverage of prophylactic oxytocin and therapeutic oxytocin, if they get postpartum hemorrhage, is almost 90%, whether they are in the low maternal mortality countries and very high. So they are all getting prophylactic and therapeutic oxytocin. But if you look at the last line, maternal deaths, low maternal mortality is 0, whereas if it is very high maternal mortality, 486. So despite high coverage with prophylactic and therapeutic oxytocin, maternal deaths are high, very high maternal mortality. Is it because the oxytocin we are giving in the low and middle income countries are ineffective due to heat instability while we transport them in ships and containers? So there has been some studies done, and it has shown that in countries as listed here, including India, if they take samples, 36% of samples are failed because this oxytocin has to be refrigerated, and in transport it loses its potency. So they have produced a drug called carbetocin, which you must be familiar by now. The duration of uterine activity is longer. Oxytocin works for 8 to 12 minutes and carbetocin 48 to 60 minutes. So that is one advantage. And they also made it heat stable. Therefore, it reduces enzymatic degradation. So you can keep the drug at 30 degrees centigrade for 2 years, so which is quite a good thing. Having a new formulation, it is stable at room temperature and maintains the potency for 48 months. The only thing you have to remember is this drug cannot be given in labor because it has rhythmic contraction for 48 to 60 minutes and it might cause fetal distress. So it can be given only for postpartum women for prevention of postpartum hemorrhage. And this has been studied by WHO as the champion study and published in the New England Journal of Medicine. And it has same effectiveness like oxytocin, whether we are talking 500 milliliter or 1 liter of blood loss. The reason it is done as a non-inferiority study because of double-blind randomization, both drugs were kept in the refrigerator. If real-world study is done, then carbetocin might show some improvement over oxytocin. Now, this has been the worry. So Cochrane did a network meta-analysis by Gallows, and I will explain this network meta-analysis a little bit better because not all drugs are compared directly with each other. So network means you can compare misoprostol with ergometrine and misoprostol with oxytocin, but you can compare ergometrine with oxytocin through the network meta-analysis. So if you look at carbetocin and oxytocin, there are 10 big trials done with 30,000 patients, and we can look at the results. And the results shows the best drug for prevention of postpartum hemorrhage, both 500 ml and more than 1 liter, is a combination drug called ergometrine and syntocinon, called synthometrine, or purely carbetocin, or if you're using syntocinon, then you have to use misoprostol on top in order to reduce the risk. As you could see, the relative risk. If you use syntocinon alone, it is not adequate. So based on the results, another way of interpreting is 10.5% of women given oxytocin alone will get a blood loss more than 500 ml. Whereas if you give a combination drug, ergometrine and oxytocin 7.2, and carbetocin 7.6, and misoprostol plus oxytocin is 7.7. So if you have a high-risk patient after delivery of a multiple pregnancy, fibroid uterus, prolonged labor, then syntocinon alone may not be adequate. But having that, usually we give syntocinon IM. Recently, there have been a study by Deirdre Murphy and a group from Ireland which shows syntocinon giving intravenously very slowly might be better than IM. Now, we have to look at efficacy, but also side effects. Side effect profile, if you take carbetocin as 1 for nausea, vomiting, hypertension, and fever, it is the lowest side effects with carbetocin compared to the combination drug of ergometrin and syntocinon, or misoprostol and syntocinon. As you know, misoprostol causes temperature shivering, and ergometrin can cause coronary vasoconstriction, so it's contraindicated in cardiac and hypertensive patients. So based on all that, carbetocin seems to be more favorable side effect profile and better efficacy. And it is going to be produced in India, so it will be something of a welcome move. And this is based on the meta-analysis. This is the WHO recommendation for prevention of postpartum hemorrhage, oxytocin, carbetocin, misoprostol, ergometrin, and metha. That's that in order. And the first recommendation, oxytocin, IV or IM, depending on the situation. And IV, as I mentioned, is a little bit better. So it reduces what can cause hypotension. So you have to give it very slow IV. Recommendation 2 is carbetocin, 100 micrograms IM or IV, but it is recommended in the context of cost comparable to other effective uterotonics. So hopefully the cost will come down, and the WHO has put it in the World Health Organization model list of essential medicine. So the governments are obliged to take carbetocin and reserve it, and that might be useful. In terms of cesarean section, the anesthetists are involved, and this is a consensus opinion from a number of countries put together. And if you look at item 6, you can see carbetocin is a long-acting analog of oxytocin with similar mechanism of action and adverse effect profile. The increased duration of action compared with oxytocin eliminates the requirement for infusion after the initial dose, therefore becomes the preferred first-line drug rather than oxytocin. So that is actually for prevention. Now we go to early treatment if she starts bleeding, and the first line is tranexamic acid because it reduces the degradation of the clot within the uterine vessels. So it prevents clot breaking down by binding to the lysine binding site. So it's a synthetic derivative of amino acid lysine, high affinity for the lysine binding site, and blocks the sites and prevents bleeding. So in other words, once the uterus contracts and blood clots in the vessels, it maintains the clot without letting it dissolve. And there have been a large study called the Women Study, which I had the fortune of chairing the steering committee. And as you could see, the death due to bleeding was reduced by 30% compared to placebo. There were deaths due to other reasons with single numbers, and that was not different between the placebo and so on. So the conclusion of that is maternal deaths following PPH are due to a number of reasons, equal in placebo and tranexamic, but deaths due to bleeding is significantly reduced by tranexamic acid. This is in a meta-analysis form. You can see if you give it within 3 hours, the benefit is much greater. After 3 hours, it has no effect. And it is effective for vaginal delivery or cesarean, or whether it's for uterine atony or trauma. So much so we know in CRASH 2 study, which is on trauma victims, they give tranexamic acid by the roadside to reduce the bleeding. So deaths could be reduced due to PPH, whatever the method of delivery and whatever the cause, if you give it within 3 hours. Now, people are worried about thromboembolic events. So this has been studied as well in these 20,000 women, and whether venous or arterial side, the number of thromboses were equal. So in other words, similar in both groups and small numbers. So tranexamic acid doesn't promote thrombosis, but it prevents the clot from lysis. Systemic complications are similar in tranexamic acid and placebo, so there is no danger of the drug. Now, if you combine the 20,000 of PPH and trauma 20,000, 40,000 cases, it causes reduction of death in these two categories if you give it within 3 hours. So in other words, for every 15-minute delay, there is a 10% decrease in survival benefit. So this has been also studied in detail in these 20,000 women. As you could see the graph, when it comes to 180 minutes, the advantage of giving tranexamic acid goes up. And this is because by 180 minutes, the blood has very little clotting factors, and the clot is not so hard or binding, and so there's no purpose of tranexamic acid. The earlier you give, the better the benefit of tranexamic acid. So based on these trials and the other trials, WHO came with a recommendation. It has to be given within 3 hours, and it is critical it is given as soon as possible. And 1 gram doesn't work. 30 minutes later, you have to give another gram. So it reduces death. And also it shows reduction in laparotomy due to bleeding by 35%. Unfortunately, it did not reduce hysterectomy because most of these countries, they resorted to hysterectomy because they didn't have blood transfusion, and therefore that benefit was not shown. This is an important study from Jaffna, which is closer to you in Sri Lanka, showing that oral tranexamic acid might reach pharmaceutical level within 1 hour. So even if you don't have IV, you can give it intramuscular. It's still better. But if you don't have, there's a possibility that you might be able to give it 1 hour oral administration. So this is a group with whom I work, and they are studying. This is pharmacological study. They are doing clinical studies now. Now, moving on to early treatment, if the drugs don't work, there are different balloons like this Ebb balloon, uterine and vaginal balloon, but also there are suction devices. I had the fortune of working with a group, which is a standard suction tube put into a loop, put into the uterus, and there's an occlusion balloon at the cervix and applies 70 millimeters mercury, and it collapses the uterus. And similar studies have been done by Samathanaram in Kerala. So this is how it looked, our device which I was working with. You put them with the suction, the uterus will collapse. And I won't go through in the details. And this studies has been repeated in large numbers because it's a good concept and it's promising. The ideal suction pressure, we use 70 millimeters, Samathanaram used more than 600. So we think 70 to 90 millimeters is more than enough. And we used a suction tube and covered the outer holes so that the endometrial tissue doesn't get sucked into the tube. So there is still study needed. So this was done by Mary Elton and a group using the device I showed you, and it showed that bleeding stops within 3 minutes in most of the cases, 65. 4 to 5 minutes, another 15 to 20%, and so on. And ease of use also is documented, as you could see. So it's not difficult. You don't need to wait and assemble a balloon kit and give it. And Professor Piley has devised a clamp which he puts through the vagina to occlude the uterine clamp. I have no experience on it, but he has done a lot of cases and it is worth reviewing. That's for early treatment, as I mentioned. If all fails, you have to do a hysterectomy. And finally, about placenta excreta, the things to remember, either you decide on a conservative management and remove the placenta. If you want to do a hysterectomy, you have to make sure that you leave the placenta. If you remove the placenta, there will be torrential hemorrhage. So as you can see in the picture, the umbilical cord is coming out. And if you're doing a hysterectomy, you can do a subtotal if you can go below the placental extrusion. But if you want to do a total because it is invading into the bladder area, there are large vessels from the base of bladder, and these are new vessels that will be pulsating. And if you use a Swabon holder to push it down, it can cause torrential hemorrhage. So this is from Palacios from Argentina. And he advised separation of each new blood vessels and tying before hysterectomy. Now, in St. George's, we had this problem, and we discussed with Jose about placenta invading the bladder and what to do, and otherwise we might injure the bladder and so forth. So Edwin Chandraharan, who was my senior lecturer, devised this procedure called the triple P procedure. The 3P means place of occlusion balloon in the internal iliac and the uterine, so that in case she bleeds during surgery, you can blow it up. Second is placental localization, so you can go above the placenta. And third is you come 2 to 3 centimeters above the bladder and cut through the uterine muscle and the placenta and take the placenta out. There'll be a large gap. The second picture shows a fibroid as well. There'll be a large gap. You can bring it together. You can put per clot where there is tissue, remove as much as chorionic tissue as possible, placental tissue, and bring it together as shown in the large picture. We have done about 50 odd cases and documented that and followed them up by ultrasound scan of the uterus, their menstrual pattern and so forth. And generally they are come to no harm. There have been a few complications like ureteric injuries, which is 2% and so forth, but nothing serious, and this can be done. And there are many other centers which are doing that. And finally, to conclude that all the hospitals must have a massive transfusion protocol, because both in casualty as well as surgical patients, and mortality declined from 65 to 2%. If you're going to give more than 10 units of blood, then you must have a massive transfusion protocol, even after 4 units, like packed red cell to fresh frozen plasma 1:1. If you give it 1:4, then the mortality is high. So giving 1:1, you can reduce it from 65 to 20%. And in surgical patient, if you give it 1:1, the mortality can be reduced from 87 to 26%. So massive transfusion protocol is important. You can use a thromboelastogram, but even otherwise, it is worthwhile. And drone technology in busy cities like Mumbai, Bangalore, and so on, because you can't get the blood in time. And we analyzed 483 cases from the women's study of maternal deaths. And one of the problems was not getting transfusion in time. And secondly was anemia. Thirdly, there was a delay in attending to the patient. So blood is quite important. So the motto of this particular talk is no woman should die due to postpartum hemorrhage. And to do that, first we have to monitor and identify blood loss, not only by just guesstimating, but because the weight of the woman and the hemoglobin will determine how she is going to respond to this blood loss. You must have observations of pulse. You can take simple rule of 30 or early warning chart or shock index, whichever method is feasible, so that you can initiate early treatment. But before that, you can prevent by heat-stable long-acting carbetocin. And if you don't have carbetocin, and if it's a high-risk case, think about IV syntocinon, but very slowly, 5 units over 1 to 2 minutes, then another 5 units. Thirdly, early treatment. If she bleeds, you give clonazepamic acid 1 gram as early as possible. If not continuing, then 30 minutes later, another gram. If it doesn't work, use the suction tamponade, which is very useful, or Tylease clamp, which might be useful. Now, triple P procedure for placental adhesive disorders, you don't need a radiology service. You can have a bulldog clamp to put it on the internal iliac before you start operating. And Professor Piley has got an aortic clamp, which he uses, and that might be useful. But most importantly, we can do a lot of things before the woman comes into labor of anemia. We can talk to our hematologist and organize a massive blood transfusion protocol. And if you're working in a place where availability of blood is a problem, I have arrangement with the blood bank to deliver the blood with drones, because that can fly over all the traffic within 30 minutes. So thank you very much for your kind listening. And this is a drone aerial picture of Taj Mahal. Reminds us all of the Queen's death, but it's symbolic. And I thank you and thank India for all their contribution. Thank you very much.
Thank you, Prof. Arulkumaran. That was fantastic, sir, as usual, and we have no words to say. And whenever we listen to your talk, we get recent advances, we get experience and evidence, and we get everything else too. And thank you very much. I'm sure there will be questions, and we will take up questions after the next lecture. And I would request you to be online till the next talk is over. And maybe now move on to the next scientific session, an equally important session. Can I have the slide share?
Dr. Deshpande. Shweta?
Yeah. Thank you. And we go on to the next session. That is to be lectured by Dr. Hemant Deshpande. He is the professor and head of the department of the Obs-Gynae at the Dr. D.Y. Patil Medical College, Pune, and he's also the deputy dean there. And he's been the dean faculty of medicine, chairman BOS, DPU, and chairperson medical education committee of FOXY between the year 2016 to 18. And he has written and edited 5 textbooks and more than 70 publications in index journals. And he had got the best publication prize for 2019 of Jogi. And he's been an examiner for PGs and continues to be all over the country and Maharashtra, AP, Goa, Karnataka, Rajasthan, and where not. And he's a national board examiner as well. And with the special contest to today's event, and he has written an absolutely fantastic book called High Risk Pregnancy and Delivery, which we will see over the next session, and a book which everybody would want to own and read and cherish. And Dr. Deshpande has been all over the country on lectures, and we all know him as a very lovely friend. And any doubts on anything, may it be administration or may it be on any organization of some medical issues, we can always put a phone call away to Dr. Hemant Deshpande. He's always been helpful to us. Not necessarily only on that, but even on an academic front, he's always been very, very helpful, an absolute friendly person to be with. And we will see him now talk to us on the role of PGDs on fetal growth restriction. And he is very, very fond of high-risk pregnancy, just like me. And over to you, Dr. Hemant Deshpande, and wishing you all the best in your future endeavors in Foxy as well and in the academic front. And over to you for the next lecture.
Thank you, Dr. Palaniappan, for those kind words. Respected Dr. Sabaratnam Arulkumaran sir, and all my dear friends, a very, very good evening to all of you. It's a beautiful webinar here. We heard an absolutely mind-blowing lecture by Sabaratnam sir on encompassing all aspects of postpartum hemorrhage. And I'm going to talk on a very small topic. And let me share my slides. So, making a little bigger one. Is it possible, slideshow? Let me check.
Yeah, full screen, please.
Yeah, it's done full screen.
Yeah, thank you. So it's something regarding sildenafil citrate in obstetrics and gynecology, a new molecule. Now, what it is exactly? Sildenafil citrate is a PDE5 inhibitor. It's a treatment for choice for male sexual dysfunction, especially the ED, since decades. Maybe since last so many years, which we really don't know how many years back. But today we have come across a new modality of treatment for some obstetrics and gynecological condition where the beautiful vasodilatory property of sildenafil citrate can be used. And I can very well say now it's a wonder drug that can be used in obstetrics and gynecology in many conditions. Now, what are the different roles which we can see here now? Most important thing, the endometrial thickness in IVF and obviously other ART related procedures, including IUI. And we all know endometrial thickness is one of the most important things. Recurrent implantation failure that really bothers the infertility specialist. And obviously endometrial thickness is one of the most important things there to help them out. At the same time, the second role of sildenafil is in FGR, the fetal growth restriction, along with oligohydramnias, improving the quantity and quality of liquor, as well as improving the growth of the restricted baby. Sildenafil definitely helps here. And the last one, like male sexual dysfunction, sildenafil do help in many problems of female sexual dysfunction. Coming to the first part, the endometrium and the fertility. Endometrium carries utmost importance in fertility. Implantation failure is really worrying to all IVF experts, all infertilologists and all gynecologists who are practicing the infertility. Because we all know lesser is the uterine flow, lesser will be the endometrial development, lesser will be the implantation there, more and more implantation failure will be there, and obviously the carry home pregnancy rate will be much more lesser. So we have to have good blood flow to the uterus, good blood flow to the endometrium, good endometrial thickness, and then only all these problems can be tackled. Now, how is the endometrial thickness helps us? It's one of the strongest predictor of implantation rate and ongoing pregnancy success rate. We all infertilologists, when we give the patient induction of ovulation induction, when we study two things at the same time. One, the growing follicles, growing number of follicles, and two, the endometrial thickness. These two things have to go hand in hand. If follicles are growing and endometrium is not growing, that's the worst situation. If follicles are not growing and endometrium still not growing, again it's a worse situation. So making the endometrium thickness at most more than at least 8, 9, 10 millimeter is the beautiful thickness of the endometrium which help us to have a good implantation. And endometrial growth is depending upon which problem, which factor? Obviously nothing else than uterine blood flow. How to improve the uterine blood flow? We know the uterine artery that goes to branch in the arcuate artery, which goes to branch in radial artery, that goes again to branch in basal artery, which in turn terminates itself into a spiral arteriole, which supplies the endometrium. So all these branches of arteries from uterus to spiral, they must have a good blood supply, they must have a good vasodilatation, they must have a good oxygenation of endometrium, and then only the endometrium is going to grow. So sildenafil that inhibits PDE5, and thus it increases the level of cyclical GMP. And cyclical GMP is one of the most important things in preparation for implantation, because cyclical GMP is going to improve and increase uterine blood flow by excellent vasodilatation. And this vasodilatation that modifies the number of cells populating the stroma and epithelium of the endometrium. It improves the uterine oxygen consumption. It improves the oxygen diffusion into the uterine lumen as well as the uterine endometrium. And in turn, what we get? We get a velvety, beautiful endometrium, which is absolutely ready for recepting the fertilized ovum. Either you do it embryo transfer, or it's a after the IUI, the patient going to conceive. Now, here comes the endometrial thickness important. If the thickness of the endometrium is more than 9 millimeter, 10 millimeter, 11 millimeter, absolute implantation of embryo is guaranteed, and higher will be the pregnancy rate here. And if the endometrial thickness is less than 7 millimeter, we always say there will be implantation failure. N number of causes. Just 2 days back, we had a beautiful webinar in Guntur, a coastal district of the Andhra Pradesh. So many infertilologists gathered, including my close friend and student, Dr. Uma Shankar, who is Secretary of Andhra Pradesh OBGYN Society and a leading IVF expert from Guntur. And my close friend, Dr. Nilesh Balkaude, has delivered a talk on recurrent implantation failure, RIF. And I'm really proud to say I was chairing the session. And so many good things which we learned there, which are definitely half of them, they can be tackled by a sildenafil site. Non-receptive endometrium is one of the worst things. So many reasons, maybe infection, maybe thin endometrium, maybe vascular problem, maybe a number of things. They all adversely affect the crosstalk between the embryo and endometrium. Now, what is the crosstalk? I do agree, embryo and endometrium, they talk with each other. Hi, endometrium, I'm coming here to get implanted. Will you please permit me? And endometrium says, yes, dear, please come. And that's the crosstalk between them, which is definitely going to be supported by sildenafil citrate. And if the endometrium is thin, this talk is obviously useless there. Now, recurrent implantation failure, update, overview on etiology, diagnosis, treatment, and future direction as an important topic from reproductive biology and endocrinology. A beautiful journal which is open access for all. If the thickness is 7 or less than that, obviously ART is going to be having little problematic one, and thickness is 9 millimeter, 10 millimeter, 11, 12, 13 millimeter, or even more than that, the pregnancy chances are going to be more than 50 to 75%. That shows that implantation is totally depending much more on good, thick, vascular, well-oxygenated endometrium, which says, come dear ovum, come dear fertilized ovum, and just sleep in my lap and grow there. Now, sildenafil citrate, what it does, it increases endometrial thickness by improving the blood supply. It causes vascular smooth muscle relaxation. It causes vascular dilatation, improves oxygenation, improves blood supply, and improves the increased endometrial thickness, making it favorable for the nidation or making it favorable for the implantation. So many reviews which we can get. International Journal of Fertility Sterility, Middle East Journal of Fertility Society. All these journals are quite new, 2020, 2017. All these journals, what they said that vaginal sildenafil 50 milligram at bedtime, starting from day 6 of the cycle, till you are going to give the trigger to the patient or till the date of the ovulation, works very, very well on the velvety endometrium and makes the endometrium more receptive for the fertilized ovum and improves the endometrial thickness. Both the journals are absolutely fabulous and articles are at most important one. Another article which I came across in IAIM journal of 2016, again a reasonably new one, just within 5 years old. Role of sildenafil citrate. And it is a comparative study of outcome with sildenafil in ovulation induction cycle with clomiphene citrate. ET is one of the most important thing which we are going to take. I told you, whenever you induce, you check the follicle size. Whenever you induce, you check the ET at the same time. So beautiful ET achievement. More than 8 is obviously achieved by the people who have received the sildenafil citrate. Sildenafil citrate people, group B, there ET was more than 9.64, definitely more than the group where induction was only with CC. Another article in GJRA, the Global Journal for the Research Analysis. It's an international journal. A study that was done in Western India. What it says that I do agree. A sample size is not much more. 104 is definitely good size for the fertility people or the people who are looking for after the ART treatment. What it said that the use of intravaginal sildenafil causes statistically significant increase in the endometrial thickness. And this endometrial thickness is, whenever it is more, obviously it is going to be a favorable thing for the implantation process. Another study on International Journal of Fertility Sterility, a masterpiece journal for the infertilologist, 2020 January to March, most recent one. Pregnancy in women who received sildenafil alone or in combination with placebo have shown twofold increase in comparison with the placebo group. So pregnancy rates are much more because implantation rates are much more, and all these studies have been done in the people. Sample size was more than 66, obviously, where the people have 2 prior consecutive IVF and ICSI failure. So remember, whenever there is an IVF failure, the endometrial receptivity can be improved by sildenafil and another cycle can be tried. Not only not only with the regular IVF, but even the frozen embryo transfer. Today, the era is of the frozen embryo transfer. Fertility rates, carry on pregnancy rate, carry on baby rates, and the pregnancy rates are much more better with the frozen embryo, and frozen embryo transfer is definitely better when the endometrium is much more thick and much more receptive rather than it's a pure one. So the clinical increase in a pregnancy rate in a study group more than the control group that was seen, where the patients were given sildenafil citrate 50 milligram vaginally, preferably, because the moment you put it vaginally close to the uterus, the increase in vascularity effect on the uterus and increase in thickness effect of endometrium is much more better. So what we summarize here that sildenafil inhibits the PDE5 and increases the level of the cyclical GMP, which increases in turn the blood flow towards endometrium. Increased blood flow of the endometrium will increase the endometrial vascularity, increase endometrial thickness, increase endometrial oxygenation, and this improves the rate of the implantation. And obviously, the pregnancy rates are much more better in IVF cycles, in ART cycles. Commonly used, the schedule for the sildenafil will be either 25 milligram twice a day, you can give, or thrice a day, you can give orally, or a 50 milligram vaginally can be given from day 6 of the menstrual cycle till you give the trigger to the patient for rupture of the follicle. Absolutely fabulous. I follow the same regime. Day 6 of the menstrual cycle, the moment the last tablet of the ovulation induction drug is over, I start the patient vaginal sildenafil till I give the patient 5,000 or 7,500 trigger of the human HCG injection. And obviously it works very well. I do practice many things. I don't practice IVF per se, but I definitely interested in IVF and soon will working with the IVF people too. Another story where the sildenafil is definitely important. One is intrauterine growth restriction, along with the obviously oligohydramnias. What we need here is the adequate placental function, which is at most important for the proper intrauterine development and growth of the baby. Abnormal placentation and impaired placental circulation will definitely affect the growth of the baby and can cause intrauterine growth retardation. I'm sorry, it has to be restriction, not retardation. Now, IUGR increases risk of preterm baby, reduced neonatal survival, and so many long-term sequelae, including the insulin resistance as well as type 2 diabetes mellitus with a neurodevelopmental dysfunction in all these babies. So can be avoided by giving a simple tablet. 29.5% newborns in India are having low birth rate. 18% pregnancies in India are affected by FGR, and perinatal mortality rates are 4 to 8 times higher for infants with FGR, and morbidity is presently practically 50% in surviving infants. All things can be avoided, can be tackled, can be treated by something. And what it is the sildenafil, because PDE5 is abundantly expressed in the human placental model in FGR. So what we need to give something which is antagonized PDE5, and that's one is the sildenafil. So sildenafil is one of the important things. If you don't give sildenafil, what can happen? Abundant PDE5 that will cause decreased level of cyclical GMP. That will decrease the availability of nitric oxide, and in turn there will be vasoconstriction at the placental bed, reduce uterine blood flow, reduce fetal blood flow, reduce AFI, that is amniotic fluid index of the baby, and in turn the fetus is complicated by intrauterine growth restriction along with oligohydramnios. So what we need to give, we need to tackle the increased levels of PDE5, that is phosphodiesterase type 5 inhibitor, and that's the one is the sildenafil. So sildenafil decrease arterial pressure, and sildenafil improves the arterial perfusion in human placental model. Thus, cyclical GMP levels are increased. Availability of nitric oxide will be much more one. In turn, causing vasodilatation at placental bed, at uterine arterial level, increase uterine blood flow, increase fetal blood flow, increase amniotic fluid, and obviously FGR and oligohydramnios are to some extent tackled, and they are going to be improved. So many clinical trials on FGR oligohydramnios. One is going with me in our own institute. So International Journal of Gynecology and Obstetrics is a beautiful trial here of 2018, very, very recent one. Sildenafil SC, you can say, could be suggested as a first-line treatment for FGR patient to improve both weight as well as amniotic fluid. Again, another International Journal of Basic Clinical Pharmacology. Again, recent one, 2019 December, very, very recent, just within 1 year. Study by our own Kedar Gandla from Mumbai. Sample size 2 agree, little less 50, but absolutely fabulous outcome. The Doppler parameters are absolutely improved after this particular medication therapy. Amniotic fluid index improved. The uterine artery pulsatile index and resistance index is also going to be improved, along with the improvement in systolic diastolic ratio. So live birth weight, Abgar score at birth, and everything has improved after giving the therapy. So CS, by increasing uteroplacental perfusion improves uterine artery Doppler pattern, improves amniotic fluid volume, improves fetal weight, and overall better neonatal survival rates by reducing neonatal morbidity and mortality. So SC may hold a promising treatment strategy for managing IUGR and oligohydramnios. Our own Kedar Gandla from Mumbai given a beautiful study and his reports here. Another study by Von Dadelson, citrate in IUGR. Significant improvement in uteroplacental circulation. The Journal of Maternal and Fetal and Neonatal Medicine, a beautiful journal, study even by Muhammad Abdel Syed as well as Said Abdel Salah. Both have told that significant improvement in fetal abdominal circumference growth velocity, as well as improving in the survival rate of the baby. British Journal of Obstetric Gynecology 2011. So many studies you can make out which are going to tell you that the vasodilatation is at uterine artery level, vasodilatation at the placental bed level, improving the placental circulation, improving the amniotic fluid, improving the Abgar score of the babies, and improving the neonatal rate. Everything can be achieved by just a vasodilator drug that helps at the level of the vascular system. Another study on oligohydramnios by Meher, Obstetric Gynecology 2017, within just 4 years. What it says that AFI has definitely improved after the SC treatment, 25 mg every 8 hourly, plus hydration was given. In turn, I mean, it's compared with the another study where only 2 liter isotonic solution was given. That's the hydration. So if you compare these two, hydration plus SC has definitely helped the patient to improve the amniotic fluid and tackle the oligohydramnios. So amniotic fluid volume has substantially improved here, and that's what they have said. Sildenafil group, the amniotic fluid volume or AFI index was 11.5 centimeter in comparison with only hydration that was merely 5.5 centimeter, practically double, you can very well say. So improvement is going to be there if the vascularity is going to improve, if the blood supply is going to improve. So improving uteroplacental perfusion, improving the Abgar score of the newborn baby, improving amniotic fluid index, improving color Doppler indices, accelerating growth velocity of the baby, increasing in the 25 mg twice a day or thrice a day can be given till the day you detected the growth restriction oligohydramnios, till the baby is going to deliver. And that's a therapy, that's a dose, that's a schedule for this particular drug SC. Now coming to the safety, in Journal of Obstetric Gynecology 2007 and American Journal of Health System, what they said, sildenafil safety is documented in more than 650 Indian pregnant patients. Category B drug, lack of teratogenic or fetotoxic effect, no increase in maternal or fetal morbidity and mortality. In turn, it's really a safe drug, can be administered safely to the patient either orally or vaginally, depending on your choice as well as what the patient she is happy with. Last thing in the SC grow, the female sexual dysfunction. It's too important as there is a male sexual dysfunction. Female sexual dysfunction that causes lot of problems in the marital disharmony. It results into the distress to the patient, interpersonal difficulties, and at times even the marriage is at the verge of breakage. So decrease in muscle relaxation, decrease in genital blood flow, uterine blood flow, increase in oxidative stress, decrease in vaginal lubrication, increase in vaginal luminal pressure, dyspareunia, vaginismus, and in turn everything that makes to the patient to reduce libido, and that's absolutely going to cause and is going to adversely affect the quality of the life of that particular young couple, and where we need to have them a proper marital life, and that can be achieved by something. Now what's that something? That something is SC, sildenafil side. So if you check the parameters of the female sexual dysfunction in the two groups, two age groups, one is between 17 to 40 and other one is 40 or more than 40. You can very well make out that comparatively everything is possible in both the groups. Low desire, low arousal, poor lubrication, lack of orgasm, obviously, and pain. Everything is associated with this FSD or female sexual function index, we can call in another term. And this can be improved by giving the sildenafil, where it inhibits PDE, increase cyclical GMP, increase nitric oxide, relates with vasodilatation, relaxes vaginal tissue, significantly increases genital blood flow, and obviously when entire female genital tract blood flow is improved, successful in treating FSD to a certain extent we can achieve. Obviously the patient needs good counseling, more important thing, and obviously patient needs lifestyle modification along with what we are giving to the patient. All three in one works very well for treating the female sexual dysfunctions. So what's the take-home message with this beautiful power pill? We can say power pill because whenever I see some Telugu movies, we always have, there is a power star, there is a mega star. So this is a power pill which you can say, power pill can inhibit PDE5, which maintains the cyclical GMP and leads to vasodilatation, increases blood flow to the uterus, to the placenta, to the endometrium, to the fetus, and obviously in turn improves the Doppler parameters, improves the growth of the baby, improves the amniotic fluid index, improves even female sexual dysfunction, or it treats the female sexual dysfunction, and it is very, very much safe in hypertensive disorders of the pregnancy. We are giving this particular drug in hypertensive disorders in the pregnancy as a dissertation topic to one of our candidates for the people who have developed something like FGR plus oligohydramnios in hypertensive disorders in pregnancy. It works everywhere. Even it tackles hypertension to a certain extent with its vasodilatory effect. So in turn, the medicine is definitely a power pack one and obviously helpful in many gynecological as well as obstetric problems can be managed by simple either oral or vaginal sildenafil. Thank you for your patient listening, and thank you for entire Acumentis team for giving me this opportunity to share the dais with Bhishmacharya of gynecology, Dr. Sir Sabaratnam Arun Kumar. I am really humbled, sir. Sharing dais with you, talking with you is my second time I am speaking with you. First in Chandigarh and second here on this particular webinar. It's a really pride moment for me. I am really, I can't express my joy, can't express my feelings, but hats off you, sir. And today, I just give my humble namaskar to you, sir. Keep blessings on us, shower blessings on us, sir. Thank you, Sabaratnam, sir, for being with us. Thank you, sir.
Thank you. Thank you very much. Greatly appreciated.
Thank you, Dr. Deshpande. So that was fantastic. And from what we know, we could understand now that sildenafil citrate is probably the Sharvaloga Nivarani. That's what we say, the drug we use for everything, the power pack drug or the wonder drug or the magic bullet or whatever. And that's what you could get from your talk, starting from recurrent implantation failure to fetal growth restriction to oligohydramnios, etc. we could use. And thank you very much for that wonderful talk. And we have a couple of questions. And so we would have the questions and then we would go on. The first question here, Sir, Arul sir, it goes to you. What is the role of prophylactic tranexamic acid in reducing blood loss on injection at the time of incision at LSCS? Is that what you want to do? When do you give the tranexamic acid? And what is its role in prophylaxis in reducing postpartum hemorrhage?
Thank you very much. It's an excellent question. There have been 2 randomized controlled trials which has been addressing this issue from France. One is following vaginal delivery, the TRAP1 trial, and the second one called TRAP2 trial for cesarean section. Both have shown a reduction in blood loss and the need for blood transfusion. So certainly it is a good drug to use. And some people are worried because it might precipitate other side effects, although as I showed you, 20,000 crash study and 20,000 women study did not show any problems. There are ongoing studies. We have a woman 2 trial, which I'm involved in, giving prophylactic tranexamic for anemic women, because you want to give reduce the blood loss. So that we have recruited 4,500 women, but the target is 10,000. So in summary, actually, smaller trials have shown benefit both for cesarean as well as vaginal delivery. So currently, what's the place? If in India, for example, if I'm operating on a twin pregnancy, C-section or fibroid uterus or a prolonged labor, certainly I will use tranexamic acid, and that can be used just before placental separation. As I showed on the graph, within 3 hours is good, but if you give it 5-10 minutes later, it's okay. So if people are concerned, you can deliver the baby, clamp the cord, and then give the tranexamic acid 1 gram intravenously. And if she continues to bleed, another gram 30 minutes later. So yeah, certainly it is of use. And as I mentioned, if carbetocin is not available, syntocinon 10 units is much more effective than IM, but please give it very slowly so that it doesn't give hypertension. So expecting for PPH, my advice would be slow IV syntocinon and tranexamic acid. That'll save the day, especially if the woman is anemic.
Thank you, sir. There was one more question to you. Is there any role for emotional support and reassurance complementary in postpartum hemorrhage? I think she means by companionship or whatever. Is there any role in PPH?
Yes, well, PPH is an acute problem. So in any way, I think as a role of the doctor, you have to be committed so that you are there by the bedside along with somebody else and give compassionate care, because the general response of the woman is much better if there is a companion by the side and there's a compassionate care. And the companion can be the advocate, because sometimes we manage the PPH, we leave her saying everything is settled. Suddenly she can bleed because staff is not there all the time. So I think it is a companionship, compassionate care, commitment. These are quite important, even in an acute situation.
Thank you, sir. There's one more question which Dr. Sushila Rani has just raised up. What is the role of TEG, thromboelastography, in obstetrics and gynecology? So in obstetrics, so that's her question. TEG, what is the role exactly?
Okay, I think Sushila Rani wanted to bowl me out. So as usual, thank you, Sushila Rani, for that good question. Well, thromboelastograph gives the integrity of the clot, how the clot is functioning. And if the clot is getting weaker, then that means she needs additional blood products like fibrin and fibrinogen and the other clotting factors. So in some centers they use it, and some centers really insist on it to give blood component therapy. But generally, if you want to really, in a rush, there's a massive PPH, patient is bleeding. So if you want to give anything more than 4 PEC cells, it might be good to have a massive blood transfusion protocol. So anything more than 4 PEC cells. I mean, if you imagine she has 5 liters of blood and she has lost 30%, that's 2 liters. And when she has lost so much, she throws away the clotting factors with blood clots. So you have to replace that because you are diluting the blood with saline. So either you can have thromboelastograph if facilities permit, which is a good thing. But if you don't have the facilities, then you go by the rule. If she needs more than 2 to 3 units of blood, then you have to give component therapy and to have a massive transfusion protocol. So in St. George's, where I work, we don't have thromboelastograph by the side of every, if there's a problem. And if we are anticipating in the theater, we do have, but otherwise in the normal labor room. So 3 areas like a fractured femur, ruptured aortic aneurysm, and PPH. We have arrangement with the blood bank to escalate the massive transfusion protocol.
Fine, sir. And somebody's asked, Dr. Tripurasundari has asked, what is your experience with carbetocin?
Well, carbetocin is quite an effective drug. It has less antidiuretic property compared to syntocinon. It has a long duration of action, 48 to 60 minutes. So we have used it, but the studies have been done not at St. George's, but mainly in Bristol with Tim Draycott. He has done a study called iMotive, which it is actually IM oxytocin study. And as I showed on the network meta-analysis as well, it has less side effects than ergometrine and syntocinon put together, or syntocinon and misoprostol put together, and it's equally effective like the drug. So if you don't have carbetocin, you got to give symptometrin, which is equally effective, but has a little bit more side effects.
Thank you, sir.
Thank you, sir. Now, I'm sure there'll be more questions, sir. We'll move on to Dr. Hemant, and we've got a couple of questions, Hemant, sir. Here they've said, is the vaginal or oral preparation same tablet you use sildenafil citrate, or is it different, use a capsule or a gel or something like that, or is it the same tablet?
Same can be used, there is no problem. Don't worry. Same you can use orally, the same you can use vaginally. See, it depends. In some houses, there is no privacy. So at times we say you can take orally, there is no harm. When the patient is having reasonably place where she can insert herself the tablets and all, she can use it vaginally. We want it close to the uterus for better effect. That's the only way.
The second question to you is, how long do you give subcutaneous, sildenafil citrate in oligohydramnios and IUGR? How long would you give?
The moment I detect it, sir, I start it till I deliver the patient, till I induce. Because we want the baby more in uterus rather than the baby in ICU or in the incubator. So let the baby is better in the uterine cavity, supply by more and more oxygenation and more blood to the baby. And that can be achieved by a little small vasodilator tablets.
The next question is, can it be given empirically before IUGR sets in or oligohydramnios, just like aspirin? I think that's what their question is. So could you give it empirically?
Sir, I think can be given. There is no harm in giving, but preferably vaginally if you have to give, which can avoid so many side effects of this particular drug, and it will be close to the uterus. And it's a good thing. I think we can have a short-term students project on this particular topic. Whoever has suggested, I say thank you. This is my new topic for our short-term students, which I'll be giving soon.
Okay.
Is already doing it.
Yeah, but that's an oligo and hypertension.
Yes, and you also can start it. Really good. Fantastic.
The next question from Dr. Tripurasundari is role of dose of sildenafil citrate in female sexual dysfunction. I thought he's already mentioned it. You could go 25 or 50, right? Yeah. So those questions have been taken, and there are before there are any more questions.
Timing of sildenafil, sir, in SDF.
Time of sildenafil citrate in sexual dysfunction, madam.
Yes.
Orally, when you are giving 3 times a day, or at bedtime when you are giving 50 milligram to be taken practically somewhere at amount. I always ask them to take prior to the meals. Remember, this is the tablet which I ask them to take prior to the dinner. That's what is more important one. If they are taking 50 mg at bedtime, or otherwise 25 mg 3 times a day, that's a routine schedule which you can advise.
Thank you, sir. I think we've had quite an interactive session on the question answers, and now it's time for us to go on to the dessert topic for the day, that is the book launch. Aren't you ready, Reshmi?
Oh, yes, sir. I think with your kind permission, before the book launch, I was just wondering, whether we'll be doing justice. Rajesh, sir, can you see the screen?
Yeah.
I was just thinking that before we launch the book, the forward is from Sir Sabaratnam Arul Kumaran. And I would want all of you, I'm so sure that it's a breathtaking kind of movement. And it is, one second.
Rashmi, there's generally no need because people know me, so I'm sure.
No need of scrolling through?
No.
Just give me half a minute. Me and Palaniappan sir, we were just surprised and shocked, whether we should be showcasing. In fact, while Googling also, we found that Amitabh Bachchan, the most famous actor in India, he also did just 200 films, and here is a person with all of amongst us who has done more than 340 publication, editorials and books and chapters. Look at his degrees, qualification, national honors, immediate and past appointments, administrative appointments, membership of professional society. And besides all this, he also does, humanitarian other services. So that's fantastic. His academic activities. Look at almost 2 to 3 lectures and orations, conferences, papers, abstract, and it is endless. You can just see, and this is about only one doctor that we are showing and showcasing. 6 abstract every year. This is super amazing. Dr. Palaniappan said that it is going to be super challenging.
Amazing.
I'll wrap it in one. And I said, I'll be able to scroll it very fast, sir. And this is how. So this is endless achievements by Sir Sabaratnam Arul Kumaran. And Dr. Hemant Deshpande was really glad and was giggling with joy that editor-in-chief of book High Risk Pregnancy and Delivery is through the forward by Sir Sabaratnam Arul Kumaran. Yes, my scroll, I'm pressing it very fast, and this is how has been his achievement. For youngster, it is a breathtaking. You can do yoga as well while the screen is on. Yes, so almost.
Highly inspiring, Rashmi, highly inspiring, yeah.
Yes, it is very, very inspiring.
Thank you for sharing. It just shows that it's time for me to retire.
In one word, I can say.
Sir, yes, sir, Deshpande, sir.
Rashmi, in one word, I can say, sir is Bhishmacharya of gynecology.
Absolutely.
Yes, Bhishmacharya of gynecology. Nothing less than that. Such a big achievement, nobody can have. Really?
Yes. And here is the launch of book High Risk Pregnancy by Professor Hemant Deshpande and our associate editor Priyanka Daya. I will stop sharing. And the session is open, and we have doctors who have to share that book.
Yes, sir.
So let's open. May we request all the doctors, yes, to please raise the book. We have been getting a lot of requests for this book also. Oh, wow. So let's open this book. Wow.
Good evening, Hemant. I didn't know that there will be a request to show the book, but the book I was reading, so I am happy to show it to you, everybody. Good.
Thank you, sir. Thank you.
Can we have all the doctors here? I can see Dr. Hara Patnaik also, Dr. Chaudhary also, Dr. Parag Shah is also there, Dr. Sojanya is there. Can we have all of them? I can see Dr. Tripura Sundari Madam also, Dr. Shah also, Dr. Shruti, Dr. Priyanka Khare, all of you? Yes. So Shweta, are you done with the photo session?
Yes, ma'am.
Sabaratnam sir here. Thank you, sir.
Doshi. We have Dr. Ashok Kumar from Delhi also has joined. Fantastic. Yes, Dr. Palaniappan, over to you now. If you want
that
to
is fantastic. And thank you, doctors, for sharing that first page of the book and the foreword by Professor Arul Kumaran. That was fantastic. And we take this opportunity to congratulate Dr. Hemant Deshpande for this wonderful gesture. And it is fantastic. And we wish you many more achievements, laurels, kudos in academic life. And Reshmi, now let me just have the honor of inviting a couple of doctors to speak and rate about the books. Dr. Sujaina Joshi, I thought he was here. Dr. Sujaina Joshi, you're there. Please switch on your video. I request the others to mute their mic and keep your videos on. Dr. Sujaina, you want to say something about the book?
Sir, you have to unmute yourself.
Unmute. Dr. Sujaina, please unmute.
Joshi sir, please unmute.
Sujaina sir, please unmute.
Sir, you are not audible. Please unmute yourself.
Yeah.
Yes. Good evening to all.
Good
At the
evening,
outset, I bring warm greeting from Ballari to Professor Sabratnam Arulkumaran, sir. Thank you. Good evening to all. This book is actually the second edition of his popular book of my friend Hemant Deshpande, which was very popular, and it's the second edition. There is a lot of changes in the second edition. A lot of chapters have been added, and the existing chapters have been upgraded. And I should say this is very useful for the postgraduate students. And about Hemant, one word. Hemant and myself are associated with each other for almost 3 decades. We have been traveling all over India, giving classes and lectures to postgraduate students. And the popular one was the Force Foxy. Almost we went all the places in India. And when he became a chairman of Medical Education Committee of Foxy, he did a wonderful job, I should say, fantastic job. And I always remember the 3 CG Saraya CMEs he conducted, one in Agra, one in Ahmedabad, and in Bangalore, and they are excellent. He's a teacher by heart. His passion for teaching is excellent. I wish him all the best, and I wish him that he occupies better posts, higher posts in Foxy and serves the academics, medical profession. Thank you very much.
Thank you, sir.
Thank you, sir. May we now move to Dr. Tirupura Sundari from Hyderabad. Madam, would you want to rate the book and tell it in 2 lines? Over to you, madam.
Yeah. I'm very happy to be part of today's webinar, and very happy to be with great people like Savaratnam sir. And I know Hemant Deshpande for almost for the last 20 years. We were co-examiners. He had visited our college and so many times. He had asked only the basic questions, which I think today's PGs may not like. But we can learn so many things from his every visit he had, we had learned anything. Here I just wanted to share my own experience with this thing, one minute, with sildenafil. Here I am, 1 minute. So this is welcome to Hyderabad, and we have been working at KIMS Hospital, and we have been using sildenafil in our hospital as a thesis for our PGs. This is an ongoing study involving nearly 20, just a minute. We have been giving till now 52 patients. And between 24-30 weeks of pregnancy, we have picked up all the IUGR patients. And in that, we have given sildenafil. After seeing the full history and the examination, ultrasonography examination was done, Doppler sound also was done, and patients were followed up for 6 weeks. We gave 25 milligrams sildenafil, that is alive or vaginal, for 3 times a day, and it was given for almost 3 weeks. Fetal growth retardation, uteroplasmal Doppler recordings were done. And the increase in fetal weight, we have seen around 100 to 200 grams, and the fetal Dopplers reversed in most of the patients, and pregnancy could be prolonged up to 8 to 10 weeks. Fetal outcome was better. And even infertility also have been using both in a thin endometrium, and it's a permanent damage to the thing. When you see, especially endometrial resistance is there, we have been giving sildenafil citrate here also. 34 patients we have been given till now who failed to get adequate endometrial thickness, ovulation and induction. Sildenafil was given along with estriol and calcium citrate 5 to 15th day of every cycle, along with estrogen and camophene, and effervescent tablets were given. Follicular study was done. Follicular growth and endometrial thickness are measured. good endometrial thickness 8 to 9 millimeters seen by using sildenafil. So we all know, as Hemant sir has told in detail, that sildenafil is a promising drug in obstetrics and gynecology. And we can, I think more and more studies are needed to say this is a good and safe drug. And I think we must be using it more. PG should be doing that so that we can get a better outcome, and we can be more safely using the drug in our future. So that is my experience with sildenafil in our institute.
Thank you, madam. Thank you very much. And Dr. Shobha, over to you, Dr. Shobha Guri from Bangalore. Dr. Shobha, you're muted.
Yeah. Good evening, everyone, and special greetings to Arul Kumaran sir. Sir, it is so wonderful listening to you, and every time I think it is a great learning experience. There are no words. Today also there were quite a few newer things that I think we can directly put into our practice. Thank you very, very much for that lecture. And Hemant, you are so lucid and as always, and wishing you all the best. Well, about this book, I must say that I am very thrilled to be part of this launch, because as one of the previous speakers said, it will be very good. I think Dr. Joshi said that it is very good for the postgraduate. Especially, I felt that this time there has been very good coverage of organ transplant, pregnancy following that, and human banking has been covered, which is so very important today. It's definitely improving the outcome of preterm infants today. Onco-fertility, and there is a high focus on the delivery aspect of all the high-risk pregnancy, I think, which is very important. And I'm sure that high-risk pregnancy will not remain an indication for cesarean if we learn more and more from books like these, and we will have better obstetricians. Thank you so very much for making me part of this. Thank you, Acumentis. Thank you, Suvir.
Thank you, Dr. Shobha. Dr. Venkatesh from Bangalore. I thought I saw Dr. Venkatesh here. Dr. Venkatesh, are you there? Fine. Dr. Sushila, yeah. Dr. Sushila, you want to think about the book? The book, Dr.
Yes. Can I?
Sure. Most welcome.
I received a copy of the book from Dr. Suegna Joshi from Dr. Hemant Deshpande through Dr. Suegna Joshi. And the moment I received, I just, any book that we receive, it's such a pleasure to receive a book on hand, unlike a virtual book. You simply run through the pages. You're very curious to find out what is written. And I went through my favorite topic of gestational diabetes mellitus, written by Dr.
Prahlad Kushtagi.
Prahlad Kushtagi. And then I also ran through a couple of other chapters. I found them all very lucid and very interesting. And the topics, like Dr. Shobha said, you have covered certain topics which are generally not covered in other textbooks. So very wonderfully presented, and wishing you all the very best. And I'm sure it will be a good textbook for the postgraduates. Thank you for giving me this opportunity to share my feelings, Dr. Hemant. And wonderful, sir. Wonderful to listen to Dr. Arul Kumaran as usual. There's always something to learn, always something more to learn from him. And it's a pleasure to meet Palni also in this platform.
Thank you, Sushila. The pleasure is mutual.
Thank you, Sushila.
And now may I request Dr. S.N. Agarwal from Virat. I thought I saw Dr. Agarwal's screen. Dr. Agarwal, are you there? I thought I saw him. Dr. Agarwal, please switch on your video, and if you're there, it will be nice if we could have you on the screen. Okay. He will come.
Dr. Vivekanand seems to.
Yeah.
Dr.
Good evening to all.
Good evening.
I'm Dr. Vivekanand. I have been associated with Dr. Hemant since 25 years, and is a second volume of this book, and it's absolutely fantastic. And that too, Dr. Sabaratnam, Arul Kumaran giving a forward adds to that, something like the icing on the cake for that. And as usual, the book is something like for postgraduates, it's a must read, I should say. And also for the practitioners. Both ways it is good, and the chapters are well written, well edited. Again, one more feather in my friend's Dr. Hemant Deshpande's cap, and many congratulations to him and the whole team, and wishing him all the best for very higher positions in a great Federation of Obstetrics Society of India. And it is my pleasure to be associated with the launch of this book and the wonderful topics, especially the Dr. Arul Kumarans and Dr. Hemant Deshpande's. Thank you for the opportunity. Thank you.
Thank you, Dr. Vivekanand. May I now request Dr. Padmini Prasad from Bangalore. I thought I saw Dr. Padmini online. Padmini, yeah.
Good evening to you all. It is really a great pleasure to be with you all for the launch of the book and to listen to great talks by the stalwarts. And so the book is really a very highly knowledge-filled book, I can say, from A to Z of every aspect of each chapter and each aspect of the high-risk pregnancy you can make out. And I have had quite a good experience with the sildenafil tablet, because I am also practicing sexual health, sexual medicine. So I have used it as it is in infertility. Most of the time, the ladies will also be suffering from lack of arousal and lack of desire. And it is a very good drug to improve the genital circulation, blood circulation, so that helps them in a proper arousal and for the sexual dysfunction treatment. And as a part of improving the implantation in infertility patients, definitely it has helped. And have had quite a good experience with Aliver. And we can use more and more cases. I think we need more studies, even in fetal growth restriction and other aspects of it. I am really very happy that I am a part of this program. I congratulate Dr. Hemant Deshpande for this wonderful book. And really, if you keep one book, I think most of the aspects and most of the references you can get in one book only. I'm happy about it. And once again, congratulations to you all. And thank you for giving me this opportunity.
Thank you, Dr. Padmini. Sure. Dr. Shruti is here. Dr. Shruti, you want to say something? Dr. Shruti from Hyderabad.
Thank you so much, sir. I'm actually very excited to be a part of this panel. And Hemant Deshpande sir and Soyagna Joshi sir, I have been their student and I have attended all their PG training programs, and it is a great pleasure for me to be on this platform today. And I am practicing infertility in Hyderabad. Sildenafil is something I use in all my patients for a frozen. Most of my cycles are only frozen embryo transfers. So it gives an excellent receptivity to the endometrium, and the triple line pattern is fantastic. Especially as sir has already told, in repeated implantation failures, this has really worked very well, and I definitely recommend to use this. I use in all my patients. If I have 10 cycles for APT, almost 8 patients of mine are on sildenafil to improve my success rate.
Thank you, Shruti. That's quite a learning point. And now I thought Dr. Venkatesh is joined. Yeah, Dr. Venkatesh. Dr. Venkatesh, you're muted. Dr. Venkatesh, please unmute yourself. Dr. Venkatesh, we are able to see you but not hear you. Please unmute.
I think Palani, Dr. Amita Chaurasia also wanted to.
Fine, Dr. Amrita, yeah, I saw Dr. Amrita, yeah.
Dr. Amita Chaurasia.
Yes, sir. Yes, sir. Thank you, sir. Good evening to all the dignitaries and the participants who are present here. I'm really honored to be a part of this book launch as well as this wonderful webinar. Both the lectures were so good and so like basic yeah. Am I audible to you?
Yes, ma'am. Yeah. Yes.
So, Dr. Arun Kumaran and Dr. Deshpande, both the lectures were very good. And about the book, I would just like to say that I just have gone through certain chapters. Each and every chapter had been given a special keen attention and interest by all the authors. And that is wonderful book for the postgraduates covering all the high-risk obstetrics. So that's a wonderful book. I have also asked my residents to purchase that book. I'm in MLN Medical College, Prayagraj from UP. And about what to say, yeah. And about sir, what to say? Everybody is a witness of his dedication and dedication towards his work. As a chairperson MEU committee, sir has extended his contribution to all the states, almost all the states of the India, to organize Foxy Force. We also organized in the month of November under his leadership. And it was a wonderful experience. And CG Saraya CME, such a successful CME, more than 5,000 attendance. So that's commendable. And sir, I'm really obliged to be associated with you. Thank you so much. And I wish you all the best for every venture you have in the future. And we are all always with you, sir. Thank you so much, sir.
Thank you, Dr. Amrita. And Dr. Venkatesh, yeah, you're unmuted.
Thank you. Hello, Purani, how are you?
I'm doing good, Venkatesh. Go on.
Thank you, sir. My heartfelt congratulations to Dr. Hemant Deshpande for having given this opportunity to launch his book. In fact, I was part of the book in the first edition, and due to certain domestic situations, I could not be a part of the second edition. However, all said and done, it's an excellent book. I strongly recommend for all the postgraduate students in training. And I also congratulate the organizers for involving Dr. Sabaratnam Arulkumaran sir, whom had very pleasant memories of hosting him in Bangalore a few years back. And I was personally liaising with him from the venue to the hotel, and I had a long chat with him. Probably he might have forgotten me now, but excellent take-home messages, and I once again congratulate Dr. Hemant Deshpande for his future endeavors in Foxy, and wish him all the best for the vice president's election. Thank you very much.
Venkatesh, you know what? Dr. Arul will never forget whatever chat. He will tell you the memories more than what you would remember. That's the best thing with Prof. Arul.
Correct. Thank you. Yeah.
Dr. Hara, I saw Dr. Hara here. Dr. Hara, please, waiting for your comments.
Good evening, and thank you, Dr. Palani, for the opportunity. Are you able to hear?
Yes, Hara.
Last time.
Thank you, Hemant bhai. Professor Arulkumaran sir,
I was a part of
my regards to you. And Palani, you are very right. And I just want to remember one thing during AICOG 2018. Professor Arulkumaran landed from an international flight at a dead of night.
3-4 of us.
And unfortunately, his car was waiting in the domestic terminal. And he did not do any fuss, and he came of his own to the hotel.
Same thing happened with
and we are really very sorry.
Both of
and
them,
that speaks great of Dr. Arulkumaran sir. I hope you have excused us for that. Second thing, Professor Arulkumaran is very crisp, and his presentation, his talk is like Veda for us. And he speaks from his heart, and he speaks newer things, and we always hear that there is some message always there, and he is onto a lot of research every time, and that's great.
Thank you, Hara. Dr. Hara, you're muted. You're muted in the middle.
Your Dr. Hemant presentation on the power pill, sildenafil, was really excellent. And we do use it in female sexual dysfunction as well as male sexual dysfunction, and in case of vaginal conditions in IVF and IUI also. So there are a lot of papers are there. Thank you for putting up. And third thing, regarding the book is really excellent. I am very happy, and I feel happy that I am a part of it. And you have the chapters are well written and well edited, and they are in chronological order. That's great of you. You have done excellent work as a chairman of Medical Education Committee, as a great teacher, and I hope you will go higher and higher. I also join all the people present here for your success in all your future endeavors. Thank you very much, and thank you, Palani, for giving me this opportunity.
Thank you, Hara. I thought I saw Dr. Munjal Pandya here. Dr. Munjal, you're there still?
Sir, I'm there, but I'm not allowed to open the video. I think I can ask the host to do so. Meanwhile, I'm audible, right, sir?
Yeah, very much. Very clear.
You are audible.
Yeah, the video is not somehow okay. It's fine. Sir, you told that Bhishma Pitama about Dr. Arukumaran, sir. You are actually the Pablo Picasso of this particular subject and branch. I know it is very difficult
you said
to
Picasso,
cope up with
your
your
video
expertise
is
with
on,
regards
sir.
to yeah. So, sir, basically, I just wanted to convey that it is very difficult to cope up with your expectations and the expertise you have. When we write a chapter under your guidance, it is always a pleasure because you start with such a minute details of why and what and where. And then it comes to the completion of the chapter. It is not about writing few words. It is about explaining what it is, why it is, and how it can be done or improved upon. So you are you are a Pablo Picasso for sure. You are an artist, and you have this particular masterpiece in form of this particular book and many other books. And it is always a pleasure to be a part of your project any day, anytime. Even if a person is pretty much busier with his or her own schedule, he or she won't be refusing to any of your projects because of this particular characteristics you have. And you inspire a lot of people, much more than you know, sir. So thank you so much, sir, for making a part of it, sir. Thank you so much, sir.
Thank you.
Thank you, Munjal. I think Nilesh has been traveling quite far. And Nilesh, you want to say something? Yes, Nilesh. Nilesh, you can speak. We're able to see you.
Am I audible?
Yeah, very much.
Yes.
Yeah, actually, I'm not getting the audio that much clearly. But to speak about Hemant sir, I think it's like watching the sun with our bare eyes. And that's, I think, far more than a teacher. I have been with him for last 10 years, and he's being a guiding force, guiding principle, a fatherly figure for me. I lost my father in 2005, but I do see my father in him. He guides me throughout my journey, through Foxy, through POGS. So our relation is much, much more. But I think talking about Hemant sir on an academic front, and the book has come out very much nicely. I'm happy to have Arul Kumaran sir releasing this book formally and writing a foreword for this. We know that he's also being a father of gynecology for all of us. But Hemant sir, you have really sculpted so many lives with your hands, and one of them is me. I took my medical post-graduation in Solapur College, but finally I came to D.Y. Patil Medical College, where I found a great teacher in you. And the tenure was enormously great. The free hand you gave me for setting up a laparoscopy unit. So our HOD unit became the laparoscopy unit, and we did more than 500 laparoscopic surgeries in just over a time span of 3 to 4 years. So that was phenomenal. And same.
Nilesh sir, you have to unmute, please.
You're all.
Yeah.
Am I audible?
Yeah, audible.
Yeah. So your all programs are grand, and we saw a grand celebration of the CG Saraya CME for all the 3 years, and it was more than 5,000 audience every time. So we have 35,000 Foxians, and out of which all 5,000 were present. The hall was jam-packed, and you gave me the opportunity to host that program. I'm thankful for that. Also, all of us witnessed the Foxy Force programs, which were a very, very grand success. So the phenomenal work, and with all the dedication and hard work you have put in as the Medical Education Committee chairperson, it will never be forgotten in the history of Foxy. So I think still more to come from you, still more to come in Foxy, sir. We all expect you at a higher position in Foxy. So in the end, I would like to say a shairi for you. Abhi to, yes. अभी तो पूरा इम्तिहान बाकी है, अभी तो पूरी मंजिल बाकी है, अभी तो तोली है सिर्फ मुट्ठी भर जमीन, अभी तो छूना पूरा आसमान बाकी.
Thank you, Nilesh.
Thank you, Nilesh. I think I'm getting signals to end, and let me acknowledge the presence of Dr. Anu Chowdhury, Dr. Indu Tandon from Lucknow, Dr. Vidya Topi from Bijapur, and it's been fantastic having all of you here. And thank you, Dr. Chowdhury, Dr. Indu Tandon, Dr. Vidya, thank you very much, and nice seeing you. Reshmi, anything more, Reshmi, or
yeah, thank you so much. Thanks all of you. Shweta,
yes,
just
ma'am.
a last word.
Yeah, I would
Dr.
just like
Vidya
to
also
share.
who has joined. Namaskaram, Dr. Vidya.
Namaskaram. Namaskaram.
Yeah. Glad to have you. Great.
Yes.
So now the loop is complete.
I
Very
would
nice
just like
to see you.
Yeah, I was just like to share a glimpse of this webinar, and it was great to be a part of this webinar. Yeah, on behalf of Acumentis, I especially thanks to all the audience doctor and speaker doctor. I'm sure you liked this session and happy reading HRP book. Thank you so much for gracing it for us.
Thank you so much. Thank you. Namaskaram. Thanks to all of you.
Thank you.
Thank you, Acumentis, also for giving us a chance.
Thank you so much. Thank
Thank
you, Dr.
you.
Palaniappan.
Hearty
Thank you, Dr.
congratulations.
Deshpande,
Great
Arun
people like
Kumaran
Arul
sir.
Kumaran and Hemant
Namaskaram.
sir, who could participate. Thank you, sir.
Bye-bye, Arul sir.
Thank you,
Bye-bye,
sir.
Hemant sir.
Thank you.
Reshmi.
Namaste, Arun Kumaran sir.
We can keep the chat open now. Doctors who wish to move, or maybe few of you wanting to speak to Arul Kumaran sir, you can use the platform. We'll keep it open for some time.
Yes.
So great of you, Rashmi. That's really nice. Yeah.
Yeah.
But you have stopped the recording, and Palani, it was so nice. You conducted the session very, very well. You're a real smart person from Chennai. He knows the value of time, and he also knows how many questions to ask. Very nice moderation by you, Palani. I must compliment.
Thank you, Dr. Shobha. Thank you very
And
much.
I wanted to specially thank Arul sir for having given forward to our book also, which we released probably 2 years back, but we were in the middle of AICOG that time, and after that the pandemic hit, so we couldn't have a formal release like that. But being a master of PPH and of obstetric hemorrhage in general, he was so gracious to say everything he said, encouraging, for us who were making that attempt to publish something on obstetric hemorrhage. And sir, thank you so very much. And I think Dr. Sheila Mane is not here, but she joins me. And thanking you profusely for that foreword you gave for our book, sir. Thank you so much.
Thank you very much.
One small question, Savaratna sir. Sir,
Yeah.
what is the role of methotrexate in modern obstetrics now, sir?
Methotrexate for retained placenta or?
For PPH, sir. For prevention
Yeah.
of PPH.
Yeah, well, it is not a dividing cell anymore once the placenta is mature. So therefore, it is not very useful. It might cause more problems. In 1991, I wrote an article about retained placenta, adherent placenta, and methotrexate. And we thought it worked, but now we know that it causes more harm by marrow suppression, and also it doesn't really work. One example is actually in the triple P procedure, which I mentioned. In the lower segment, on the upper segment or the upper part, we cut above the placenta, but the lower one, we cut through the placenta and the muscle together. And then there will be placental tissue, we take it out, and there's any bleeding, we put some cloth and suture it. So there is chorionic tissue, but automatically it autolyzes and comes out, and the structure of the uterus is maintained. The methotrexate in many ways is not necessary, and it can cause harm. So we don't use methotrexate anymore.
Yeah. So I had a question, sir. We are getting more cases of adherent placenta in early pregnancy, and we are getting also cases of scar ectopic. And I wanted your experience with that, because there seems to be a lot of overlap between these two clinical situations. And any management experience that you can share, sir, it is very valuable for us.
Well, I don't have personal experience except a few cases, but reading the literature, I think one of the things which is useful in early pregnancy is to see whether the contour of the uterine cavity is maintained. If the contour is maintained, like the shape where you can see the cavity and the gestational sac is within the contour of the cavity, although it's partly going into the scar, then it can be an adherent placenta, but not a scar pregnancy. But if the contour of the uterus is separate from the gestational sac, that's the one which is going to be a cervical pregnancy or something which is going to give more problems. Now you asked a second question on that, I forgot. How do you manage?
Is there an overlap between these two clinical entities?
Yeah, there must be an overlap because it's not totally this or that. So there might be an overlap. But in terms of management, actually,
yes, sir.
If there's some muscle tissue which is seen outside and the woman wants to leave it and then carry on as an adherent placenta, then that can be done. But if it is a cervical pregnancy, that means the uterine cavity is separately seen from the gestational sac. That is the one which is going to give rise to dangerous things. So that might need surgical procedures. But depending on the close proximity of the cavity, on ultrasound guidance, you can suck it out or you can give, otherwise you have to do it laparoscopically or laparotomy. So you have to make the distinction whether it's a scar implantation or whether it's a cervical pregnancy to plan the management. It's easily said, but it is difficult to do.
Sir, I have a question, sir.
Thank you, sir. Thank you.
Sir, regarding the suction device you told about the control of PPH, sir, how much pressure is to be created, vacuum is to be created, and for how many hours we can leave that, like how to decide when to remove? So you have experience with the suction device to control the PPH?
So the original study what we designed was actually, I worked with a producing a manufacturer in America, and we did the study, early studies in Indonesia, where when we tried it out, essentially it's like a suction tube which you put into the abdominal cavity to suck and have a suction tube. The same suction tube, you put it into a loop and cover the outside holes with a plastic. And then you fuse the tube and you bring it down, and we used 70 to 90 millimeters mercury. That's all the pressure we used. The reason we covered the outer holes was in removal of the suction tube is much easier because the endometrial tissue doesn't get sucked into the suction holes, because the suction is created from the holes inside the loop. Whereas Samatanaram and Vasudeva Panikka from Kerala, they used a straight suction tube, there was no cover. They used 600 millimeters of mercury, so they used very high pressure. In terms of how long to give it, as I showed in one of the studies, the largest study of 130 patients in America, the 60 to 70% stop bleeding within 2 to 3 minutes, another 20%, another 5 minutes. And if they don't stop bleeding by 9 or 10 minutes, then you might have to switch on to something else. And you can leave the suction tube as long as you like, but generally the principle of balloon tamponade or suction tamponade is for the uterus to contract and for the blood to clot within the uterine vessel, and then there is no need for balloon tamponade or suction. So you want to be on the safe side. More than 2 hours is more than enough. Then you can release the suction. But it also depends on what time of the night you do. Suppose it is early morning, 2 a.m., and then I would just leave it till the following morning before I take it out. But if it is at 10 o'clock in the morning, then I will just take it out by 2 o'clock in the afternoon. Also, at the patient's condition, whether she needs blood transfusion, top her up. And once she's stable, hemodynamic parameters are stable for 2 to 3 hours, that's the time to take it out.
Thank you, sir. Thank you for this elaborate discussion. Thank you.
Thank you so much. So Dr. Palani, sir, with your permission.
Yeah.
Do we close?
Yeah.
Although we'll like to get connected again. And Sir
Sure.
Sabratnam, sir, I'll definitely block few of your dates ahead also. And I know at least 2-3 months time I need to have. So we'll definitely get connected again. Thank you so much. Thank you so much, Palaniappan, sir. Thank you all the doctors.
Reshmi,
and
just a minute, Reshmi. Sir wants to say something.
I said, instead of booking me, you can book Professor Palaniappan. And
No. I won't be anywhere matching to you. No way.
I'm sure I have every confidence you can match even better.
Oh, what a compliment.
Thank you, sir. You made my day. Thank you very much.
Thank you, everybody. Thank you very
Thank you,
much.
sir.
Thank you
Thank
so
you.
much. Thanks.
Thank you.
All the best to you, Hemant.
Thank you, sir.
Thank you, Deshpande sir. Thank you. All good wishes to you, sir. Thanks.
Thank you, sir.
Thank you.
Thank you, Team Acumentis, everyone. Thanks.
Thank you. Rajesh, thank you.
Yeah, thank you so much, sir.
Thank you, Rajesh sir.
Rashmi, thank you.
Thank you, Rashmi.
Thank you.
Thank you. It's a great event. Thank you, Rashmi.
Thank you, Shweta, and thanks to Netcast Services for